Welcome to the Chapter 20 PowerPoint voiceover for Hematologic, Immunologic, and Neoplastic Disorders, Part 2. So this is accompanying a different or an additional PowerPoint voiceover lecture that covered the heme and immune disorders in pediatrics. This one is going to focus on cancer, or what they term neoplastic disorders. So you'll notice that this PowerPoint does not contain Part 1's PowerPoint slides. It's going to pick up where we left off. It will include the objective slides, and then it will begin with the Part 2 content. Okay, so to begin, I want to mention that cancer obviously is something that impacts all patients across the lifespan. We are going to be focusing on the cancers that are most common in pediatrics, the ones that, maybe they initiate in peds patients and they may still be, potentially occurring in adults as well, or we might be focusing on them because they differ in the pediatric patient than they would differ in the presentation in the adult patient. So some of this information will be familiar to you, but it may or may not be familiar to you in that it describes the pediatric patient suffering from this particular form of cancer. Okay. In childhood, the types of cancers that are most common are ones that affect the blood and lymph system. So we're going to be looking at those, as well as what is considered the second most common, which for children would be brain tumors. Many symptoms associated with cancer are common in children in other illnesses and conditions as well. So what that means is it's a lot harder to diagnose pediatric cancer because the way it manifests in peds patients is very similar to the manifestations of many other childhood illnesses and conditions. So there may be some delay in the determination that what the patient is suffering from is in fact some form of cancer. Some children are actually asymptomatic, which means without symptoms until the cancer that they have reaches an advanced stage, which usually means that there has been metastasis or spread to other organs of the body at this point, and it's only at that time that the child is displaying symptoms that would actually lead to a diagnosis. When we're talking about cancer in pediatrics, one of the manifestations is generally pain, and that pain could be anywhere in the body. It's usually going to coincide with where the cancer is. So if it's, say, a solid tumor cancer and the tumor is in the bone, then the pain is going to be in the affected bone. But there are definitely pain is potentially the case all over the body depending on what form of cancer the patient has. Cachexia, it should be a familiar term to you, is basically the umbrella term for a patient experiencing the following: anorexia, weight loss, anemia, weakness to the body, and often a fullness feeling. So this is something that is true of pediatric patients as well. They just have this overall or general malaise in which they also are suffering from weight loss and weakness, and usually a lack of appetite. Anemia, we see this in chronic illnesses. It's when the body is, poorly using iron or is lacking in iron, and so this is a result of that. And this is true a lot of times of our patients with cancer. Frequent infections. Usually cancer is going to alter the immune system. So because of that altered or immature immune system, or even the cancer's inhibition of the normal immune system cells being able to mature like they're supposed to, the patient will be prone to frequent infections. We know that that's also true of a pediatric patient who's undergoing treatment, because the way in which cancer is targeted is to generally deplete and destroy all of the cancer cells, but in doing so also the healthy cells. And so that makes the patient immunocompromised and at great risk of experiencing frequent infections. Other manifestations include bruising or ecchymosis, usually related to a decreased platelet count. Neurological symptoms, this could mean altered level of consciousness. They could experience increased intracranial pressure. They could have changes to their behavior, changes to their visual function. Usually in those cases, it's due to some kind of brain or nervous system that's been impacted by the cancer. So we see that with the neurological forms. A palpable mass can occur, and that can be present in any place in the body, again, related to where that cancer is usually going to, fit the name. But examples include the abdomen, the neck, the lymph nodes, and that's just to name a few. And there's many other symptoms that can also be associated with manifestations of pediatric cancer that'll depend on the severity of the cancer and the location of the cancer. So these were just some primary ones that we're touching on. So brain tumors, which is the second topic, and we're going to get into each one of these with more detail in just a moment, but brain tumors are differentiated based on where in the brain they're located. So we're just going to be talking about them from a more comprehensive standpoint, but know that there are different variations of brain tumors. Bone tumors typically are divided into or classified based on their location as well. So osteosarcoma is an example, Ewing sarcoma is an example, and then so is rhabdomyosarcoma. Rhabdomyosarcoma is one of the soft tissues, whereas osteo and Ewing are both of bone. Neuroblastoma was mentioned. That is commonly occurs in the abdomen, neck, or chest. Don't confuse it with brain cancer because of the word neuro. I mean, neuro is in it, and so sometimes we might be inclined to think, oh, you said neuro, so that must be a brain tumor. No, neuroblastoma is a non-neurological brain tumor. It is one found often in the abdomen, neck, or chest, though it can be other places as well. Rhabdomyosarcoma, which we have under the bone and soft tissue category, is found generally in the head or neck, the genitourinary tract, or in the soft tissue of the extremities. Wilms tumor, that one is found strictly in the kidneys. And then retinoblastoma is found in the eye, specifically the retina of the eye. So we know that cancers vary by type and location, as do their manifestations, and does their prognosis and their treatment as well. So let's look at them individually. So we're going to start with the topic of leukemia, which is our blood and lymph system cancer, which again we said is the most common in childhood. This is one that is acute in nature, but it also can be chronic in nature. We're going to be talking about the acute form because that's generally the presentation that pediatric patients are going to have. But do know that these types that we're going to be looking at also exist in a chronic form, typically diagnosed in the adult patient, requiring generally lifetime medication management for that. The acute forms of leukemia are rapidly progressing. The difference in them is where in the body they occur, but also typically what age children they affect. So one example is acute lymphoblastic leukemia, which we abbreviate ALL. This is more common in your younger child. So our younger pediatric patients typically exhibit this form. The acute myelogenous leukemia, which is abbreviated AML, we see in the older child, generally the adolescent patient. Both are rapidly progressing cancers, but it is known that AML is less responsive to treatment than ALL. So neither is, of course, a desirable diagnosis, but as far as prognosis, having diagnosed AML is usually more severe. These, forms of cancer are most often seen in pediatric patients that are like 14 years and younger, but the myelogenous obviously can include some of those older adolescent ages as well. These cancers are cancers of the blood-forming organs. They are characterized by a proliferation of abnormal white blood cells in the body, and there is no known cause for it. There is suspicion that there may be some link to genetics, there may be some association with immune deficiency, even radiation exposure, but they cannot, isolate the cause. They're distinguished based on the blood cells that are affected. And as was said, AML more common in adolescents, ALL more common in children ages 2 to 10 years old. ALL is more common than AML in general. And as was said, AML is less responsive to treatment of the two. What are complications of leukemia? Just like any other cancer, of course, the greatest is metastasis elsewhere in the body. And so with that comes, a harsher treatment and also generally prognosis. Also affecting the growth, because we're seeing it in children so young and it's affecting their blood and lymph system. It typically does impact the child's growth, and that is growth both physically but also developmentally. So it impacts the whole child and their overall health. Luckily, most cases, if detected relatively early on, can be, and it says curable. I probably should change the phrasing on that, because, cancer by definition is not curable, but it can be managed such that the person can go into remission. So when I say most cases are curable, or when the book says that, they're talking about most cases respond to treatment and the patient can still go on to live a healthy life and be in remission, though never truly cured of cancer. Okay, so we already talked about quite a few manifestations that are typical of cancer in peds patients, but this is, for you an actual slide that outlines them. Some others that we didn't speak to, fever, obviously we would expect that, though that's not always going to be the case. Pallor or a overall paleness would be something else. We talked about ecchymosis bruising, but it also can be petechiae bruising. Remember, that's the ones that are like pinpoint bruising in different places on the body. Bleeding in different places. That could be, GI bleeding. That can be blood in urine. That can be blood with vomiting, just frequent bleeding in general, which is, something we also talked about previously when we looked at the part 1 of this chapter in talking about hematological disorders. Malaise, that overall general feeling of sickness and not feeling, healthy and normal. Depending on where the cancers are at, there can be organ involvement that can result in organ enlargement, and sometimes the need for those organs to be either reduced or removed. So either a resection of the affected portion or the whole organ taken out. Neurological changes we mentioned, especially if the cancer is infiltrating the central nervous system. And then treatment just in general typically is going to be a combination of chemotherapy, radiation, and potentially hematopoietic stem cell transplantation, or HSCT for short. Okay, so we're continuing to talk about leukemia and its multi-system effects. It tends to affect multiple systems of the body. There is a long period required for treatment. Having the knowledge of and the interpretation of a complete and thorough assessment is critical here, because this is where, we pick up on those subtle differences that might be indicative of something going on in the body, more than just the typical presentation of sickness in a peds patient. We want to assess for indicators of bleeding and indications of infection. We want to also make sure that as the patient's undergoing treatment, whatever that looks like for them, that we're monitoring for those toxic side effects. And at the end of this presentation, this PowerPoint, we'll speak to what some of those side effects are. Know that, child and family coping is going to be a big focus. We want to provide psychosocial support. We recognize that this is going to be stressful for the family, both in a mental and emotional and psychological state, but also financially. It's going to impact the attention the other children in the family are getting, the dynamic of that family, in general. And so there needs to be a support system that we're encouraging and we're helping to provide as the caregivers, in the healthcare profession. We want to provide education for the patient and the family, things like, infection prevention, spread of infection, reduction, careful hand washing, the need for, like, if they have a central line, proper central line care, oral care, just another component of it. One of the things that typically results with a lot of the treatment measures is oral sores in the mouth. They call it oral mucositis, and so needing to know, the ways in which to go about treating that and managing that, both from an infection reduction standpoint, but also a comfort provision standpoint. Other focuses would be nutrition. We talked about the patient having that general malaise feeling, that, anorexia, that tendency to have a decreased appetite. But nutrition's important, and having, a balanced diet and everything being balanced within the patient's nutrients and hydration is definitely crucial for healing. So we want to find ways to, really encourage that with the patient. Managing their pain, and that does, involve medications, both, mild forms of analgesics and also narcotics, but also other measures too, like, more complementary distraction techniques, being an example. Being aware of CNS infiltration. So this is when, we're concerned that the central nervous system is affected. We should be assessing for this routinely with the shifts taken to monitor these patients, because we know that toxicity is a possibility. And so we would expect there to be a lot of neurological changes for the patient if this is occurring. Our pain assessment and management is important. There's a lot that's going to be, required in this situation, like bone marrow aspiration or biopsies, lumbar punctures. These are very painful diagnostic measures, and they're going to require intervention on the part of the nurse for that. And we expect that these patients would be on precautions like isolation and transmission precautions because of their weakened immune system, neutropenic precautions, and educating the family on what that means, and expecting that prolonged hospitalization for these individuals. Okay, so now we're moving to brain tumor. This, we said, is the second most common form of cancer in pediatrics. It's the most common type of solid tumor in pediatrics. So we're going to look at various solid tumors named based on their location in the body, this one being the most common of that group. It's also the most common malignancy in children. There are 4 common types of brain tumors, and they're named based on where in the brain they occur. They include medulloblastoma, gliomas, astrocytomas, and epidemiomas, but we're going to be really just focusing on brain tumor in general, kind of the umbrella term, if you will. Excuse me. And you can see, more of this information within the chapter itself. So talking about the fact that this is a very common form, second in ranking to leukemia for pediatrics. The cause of it is unknown. The most common forms are the medulloblastoma and the gliomas. And what we expect as far as manifestations of brain tumors is similar to what we already were discussing just in pediatrics in general with cancer, with a focus on the following. Typically, there's going to be some neuro changes in this patient, some, changes in their level of consciousness, their alert, their ability to behave and communicate appropriately for their age. That is typically going to be altered. They may experience sensory deficits where they are having trouble, with their vision or with their hearing or other senses even. They tend to have dizzy spells. They tend to be very tired and, complain of or demonstrate fatigue. They, if able to verbalize, they would say that they experience chronic or routine headaches that are very uncomfortable. So these are some of the things that are unique to the brain tumor element that we maybe didn't focus as much on in the leukemia content or just in the cancers in kids in general. We also would typically see some gait changes if there's a brain tumor because of that impact, and then also nausea and vomiting. So I have a little note in here that brain stem tumors specifically will manifest with patients having changes in their weight and deficits in their growth and development. And so oftentimes they'll be mistaken as failure to thrive. So they may initially receive a diagnosis of FTT and then with further evaluation discover that it's actually more than that. It's actually pediatric cancer that's the source of these weight changes and these developmental deficits. The prognosis and treatment is going to depend on where in the brain it's at, the location of that tumor, and the ability to remove that tumor. So surgery is generally needed in order to remove it, and there's different ways in which the tumor can be operated on. One is debulking and one is excising the tumor. So one is when we can only take a portion of that tumor, but one is when we can ideally remove the whole thing. Excuse me. Following surgery, these patients are likely to need radiation. It says or, but it's, radiation and or chemotherapy, depending on, again, the advancement of that cancer and the location. And the way in which we want to continue to monitor them, especially in the post-op period for a brain tumor, is that we would expect there to still be the potential for changes in their neurological status. They may require a shunt for this, a VP shunt that's placed to help remove any fluid accumulation and minimize the likelihood of increased ICP. So then we have to provide shunt care. We have to continue to assess the functionality of that shunt. We need to monitor for seizures. Epilepsy occurring in conjunction with this is something that we might expect and we want to be prepared for. Obviously, I&O, fluid replacement, hydration, nutrition, all of those elements are going to be crucial. Our continued management and assessments will include a thorough neuro exam. We want to be performing that head circumference measurement. Remember, we talked about head circumference being an integral part of our assessment on children younger than 2 because we expect them to still have an open fontanelle, but it's also pertinent in situations that they have other neuro-related problems, like in this case maybe a shunt or the history of a brain tumor. Our developmental screenings should be frequent to decide if they're meeting the appropriate milestones for their age, or if they're not meeting them or even regressing, which would mean like I'm losing some of the milestones I previously had attained. And then it talks about post-op care, including side positioning, and that's for draining purposes. It would be the side opposite of where the shunt or the surgery has been performed. Okay, and the next one we're looking at, neuroblastoma. The very first bullet point on this slide is one I would recommend, highlighting, starring, underlining: tumor outside the cranium. And I did mention this earlier very briefly, not to confuse it with a brain tumor because of the prefix neuro in this name. Okay, this is not located in the brain. This is a tumor elsewhere in the body, and we'll look at specifically where in just a minute. But it is another form of a neoplasm that's associated with abnormal cell growth and can, of course, be life-threatening for the patient, as all of these cancers can be. This one is typically associated with a smooth, hard, and non-tender mass occurring along the sympathetic nervous system chain. So places include the abdomen, adrenal gland, thoracic and cervical areas, the most common being the abdomen and the adrenal gland. Very often with this particular condition or form of cancer, metastasis is common before diagnosis. So usually it's already spread elsewhere before it's found, which of course makes the management of it more difficult, as well as the manifestations of it much more broad or much broader. But the cause of it is unknown. There is some, assumption that it may have some genetic link to it. And the treatment, like the manifestations, will be based on where in the body it's occurring, the stage of the tumor, and how it responds to the different treatment options. So usually treatment will include surgery, radiation, and chemotherapy. So in some instances, we're talking about, any combination of one or more of those things. In this case, generally, it's all of those things. Surgery is ideal to be able to actually excise or remove the tumor itself. And this is usually done after the patient's undergone chemo and radiation. Chemo and radiation can then also be used after surgery. So sometimes they'll require it pre and post having surgery for this patient. And that is to help either shrink the tumor or, allow them some time to be able to get that tumor removed and then provide additional follow-up management. In very advanced cases, one of the possible complications is that this patient will require a stem cell transplantation, or HSCT for short. And so obviously in that situation, and that slide's going to be towards the end of the PowerPoint, but it's important to know what all does that entail. There's different phases of stem cell transplantation, all of which involve the patient being immunocompromised and having to be, on all of the precautions for, neutropenic and immune compromised precautions. So we'll look at that, kind of as a general thing at the end of the presentation. Management, as far as the nurse goes, is going to be both pre and post-op care. Our post-op care focusing on, fluid, maintaining hydration, respiratory care, preventing infection for this patient, providing, emotional support, whatever that looks like for that patient specifically. For the chemo and radiation, obviously managing side effects that we would anticipate with that and educating while monitoring how they're doing. And, I just have a note, and this is applicable anytime we're talking about radiation, but one of the things we need to educate on is the awareness of radiation exposure. So what are the necessary education points for the family of this child when they are undergoing radiation therapy? Okay, our next solid tumor is the Wilms tumor, and you could basically say AKA nephroblastoma, nephra being the medical terminology or prefix for kidney. So this is a tumor specifically affecting the kidneys. It's a renal tumor, very common, and usually presents unilaterally, which means it would only impact one kidney, though it is possible that a person could manifest having occurrence of it in both. This is more often associated with congenital anomalies. It is very common in our toddler population. So specifically ages 2 to 3 years, is when this is typically discovered. And typically the patient is initially going to be asymptomatic. So they're not going to have any actual changes in their health patterns or routine when it first presents. And often the way in which it's first discovered is actually the physical mass palpated in the abdomen. A firm mass in the abdomen that grows rapidly. And they may experience some of these other manifestations with it, like increased blood pressure, urine that has blood in it, changes in their bowel patterns, experiencing weight loss, or complaining of abdominal pain. But again, it's not necessarily going to include those things, whereas the mass is pretty standard. This is one where we talk about with Wilms tumor, and this would be a great approach for NCLEX as far as like what to focus on. But remember we talked about, we auscultate before we palpate. When we palpate, if we suspect a Wilms tumor, we need to stop palpation, okay? It is not one of those things where you want to, and this is just, giving an example, but whether you're a student nurse or a nurse and be the one to suspect this in a patient, feel it on the abdomen, and then go find all of your colleagues to come in and get the opportunity to palpate it too. Okay, because the concern and the danger is if we continue palpation of this mass, we have the potential to spread this infection. We can contribute to its metastasis. And that is a very common problem with these solid masses that, can be manipulated. So if suspected, and this is again a way that NCLEX would definitely focus in on this particular type of cancer. If suspecting Wilms tumor, cease palpation. Do not palpate, okay? That is usually how it is discovered. That is not something that we want to then continue. It is known to be a highly vascular tumor that can easily spread, which is why metastasis is common. Our treatment for this and the prognosis for the patient will depend on the stage of cancer and the extent of its metastasis, but this will generally result in the need for surgery, either the removal of the mass itself on the kidney or possibly the entire kidney, hence the possible nephrectomy. And they typically will also end up receiving radiation or chemotherapy with it as well. Avoid palpation of abdomen after initial assessment if suspected. Also know that pain management is going to be an important part of the nursing care and management for this patient, and that will include monitoring the patient's hydration, INO, their kidney function, making sure that they're still able to excrete what their body's excess, their blood pressure, and then also their weight. Okay, next solid tumor, osteosarcoma, is one that is affecting the bones. This is the most common malignant bone cancer, and if you remember in the first slide introducing the cancer topics that we were going to discuss, this is just one example of a bone cancer. This is the most common malignant one. It is most often seen in adolescents at the peak of their growth spurt. So we're going to find, of all the population of pediatric patients, this one impacting the adolescents the most. And anytime I'm speaking to a particular age frame with any of these, I would definitely be highlighting, underlining, starring that, because that's going to help you when it comes to an exam question. Even though the potential is there for it to be something outside of the norm or the usual, that's not how I'm going to be evaluating you. I'm going to be asking questions related to what is the typical presentation. So if I give you a patient who's 2 or 3 years old and I'm describing a solid tumor and one of the options is osteosarcoma, that's not one you're going to pick. You're going to rule that out because it's typically going to be your adolescent patient, not your toddler. Okay. So the locations can vary, but it's often long bones like the femur, tibia, and humerus. The cause of it is unknown, and the manifestations depend a lot on where it's at, but will include pain to that extremity, swelling, redness or erythema, limping, okay, some limitation in the range of motion because of the pain that they're experiencing it. It's very common for metastasis to occur with osteosarcoma. So symptoms that you would expect would include wherever else the tumor has spread to. Chemo needs to be very aggressive because of the metastasis tendency, and often surgery is needed. And in some instances, removing the tumor itself is not possible, so it may require limb amputation. And then it says in parentheses, and a prosthetic, so they would end up hopefully receiving a prosthesis after the fact. Our treatment, our nursing management is going to be pre and post-op care for the child who does require, possible limb amputation. We're going to be encouraging the compliance with physical therapy. And, physical therapy is something where in that therapy session, the physical therapist is working with the patient to complete these certain exercises and routines to regain, control and the ideal amount of movement. But it doesn't just happen at therapy. it is something that, the caregiver needs to be encouraging the patient, and the nurse needs to be encouraging the caregiver to incorporate it on a daily basis outside of just when they meet with the therapist. Obviously, emotional support is going to be crucial, especially if they did require some kind of amputation, and that might even include some kind of peer group referral. The chemo would be aggressive, and so, as well as, so this one, I have a little note that says the chemo is aggressive and it's used after surgery to increase survival, but it also is typically part of the pre-surgical efforts of treatment too. So a lot of times these patients are going to have chemo before and after the procedure. Radiation is not typically part of the treatment for osteosarcoma because it's generally ineffective. We don't see it actually helping. And then we speak to phantom pain management as well as body image disturbance, helping to help this patient, especially, since they're usually in their adolescent phase of life, to cope with the changes to their body and what that's going to look like for the future. And then just being alert for metastasis, because even with the removal of bone cancer, of that specific tumor or that limb, even the chance of recurrence is pretty high for that. Okay, Ewing sarcoma is another solid tumor that affects bone. It's a highly malignant bone tumor, but thankfully a rarer form of bone cancer in general. It is most often seen in the pelvis, chest, vertebrae, but could also be the long bones, like we just mentioned previously. It's generally a smaller round cell tumor that occurs or grows in one of these places. The pain for this typically worsens and becomes constant and severe, but it may begin as an intermittent pain that they experience. Where the tumor is located will usually be the location that swelling and erythema is expected or found. The prognosis will depend again on if it's metastasized and to what extent, and the treatment looks a lot like our osteosarcoma does, except it also includes radiation. So an important difference between the osteosarcoma and the Ewing sarcoma management is that radiation is generally ineffective with osteosarcoma, where it is an option for management of Ewing sarcoma. Surgery, chemo, and possible stem cell transplantation. Whatever extremity is affected, obviously activity needs to be discouraged for that, and weight bearing needs to be limited, especially in the, prior to treatment being implemented, because we also want to minimize the metastasis tendency for that. And, we'll obviously be addressing the adverse effects of treatment, like the side effects of radiation and chemo, as well as the pre and post-op care following surgery. So again, note that this is more rare, whereas osteosarcoma is way more common, and note that it includes radiation as being an effective treatment measure, whereas osteosarcoma does not. Okay, rhabdomyosarcoma, based on its medical terminology, involves soft tissues. So it's a tumor in the soft tissues that can occur anywhere, but often is found in either the head and neck, the genitourinary tract, or somewhere in the extremities. It says head and neck, and specifically with head, it is referencing around the eyes. So around the eyes, in the neck, in the abdomen or GU tract, or extremities. The locations, most often the muscles around the eye or neck, that is the primary two. But again, any of these are possible. It is a very highly malignant form of cancer in pediatrics that does spread easily, and it is one that impacts the older toddler and preschool age child. So it mentions between 2 and 5 years. That is when it is most often diagnosed. When it mentions the rapid metastasis, and spread. Unfortunately, this one tends to spread to the lungs and the lymph nodes. So based on our understanding of that, it can obviously be an emergency and can have a much more impactful role in the patient's prognosis. The manifestations will depend on the location. So wherever we're seeing the tumor or the soft tissue tumor is where we're likely to see the symptoms. Those symptoms will include swelling. If it's occurring around the eye, then ptosis, which we know to be drooping eyelid, and also visual changes. Even eye movement changes like nystagmus or strabismus, where there's twitching or cross-eyed is possible. If it's in the GU tract, then we would expect there to be urine changes, maybe even urinary obstruction, hematuria, so blood in the urine. You might be able to feel a palpable mass in those locations. And it can even be asymptomatic, especially if it's in the abdomen. For whatever reason, if that's its primary location, then a lot of times the patient will be asymptomatic until it has metastasized. Treatment is going to involve surgery if possible, as well as radiation and chemo, and management for the nurse will include pre and post-op care, addressing the adverse effects of treatment. Also knowing that if it is in, say, the neck region, then we have a need to really evaluate the patient's airway and respiratory function. So with all of these, it's important that you pay attention, especially in an exam question, as to where it's identifying the location of the tumor is, because that's going to dictate what are some of the complications you're concerned with and where are the areas you need to focus your nursing assessment. If I'm talking about a rhabdomyosarcoma that's in the eye or around the eye, then I'm probably not as concerned about the patient's airway. But if the location is the neck, then obviously that would make the airway a grave concern. Okay, retinoblastoma. Still keeping in line with tumors, solid tumors, in different places in the body. This one being in the retina, so in the eye. And as mentioned, it can be bilateral, though it is generally going to be unilateral. This is most often seen in children under 5, so our infants and toddlers, and then that early preschool age frame. It's congenital, so it's been there since birth. It just may not be discovered at birth. A lot of times this is one that once the patient's vision is being evaluated, for why are they not focusing on objects? Why are they not tracking? Why are they clumsy and crawling or walking into things, that we start to think, oh, I wonder if there's any visual impairment, and then specifically if this could be the reason for it. So under children under 5, but most often 1 to 2, so toddlers. And some of the things that you may notice with the patient is strabismus, which is cross-eyed, inflammation or erythema of the eye orbit, so around the eye. Headaches, which again at that age, 1 and 2, they're not going to be able to really verbalize, so it may be found by their nonverbals, like constantly touching on the head would be an example, or maybe just their inconsolability, disturbances in their sleep and play patterns, all could be associated with that pain that they're experiencing. And vomiting is also a possibility. So this is one where an actual assessment can reveal this suspected form of cancer, and that is using an ophthalmoscope head on the otoscope. So otoscope being the tool that is used by providers when they want to assess the inner ear of the patient. You can actually take that piece off that has the little speculum that they put into the ear and put a different head on that wand, if you will. That is called an ophthalmoscope head and has different features on it that let you inspect the eyes. We'll actually end up well, we won't be meeting in person for this, but this is something you could even potentially look at with your patients using your cell phones. It doesn't always work this way. So let me preface with the right instructions, you might be able to identify this using the flashlight on your cell phones. But typically, what we are expecting to see with a patient when a light is flashed in front of them and is encompassing both eyes is what they call a normal corneal light reflex, or a positive corneal light reflex, which means that the center of the pupils, there's this little bitty glimmer of light that is like reflecting when you're using this flashlight, okay? And that little light should be central in the same place on both sides of the eye based on where the patient's looking. So if they're looking, dead on at you and you're standing directly in front of them, as if they were like focusing on your nose, then that light should be visible on the center of the pupil. If their vision were, altered, like they were turning to look elsewhere, then that might be located elsewhere on the pupil, but it's still going to be the same place bilaterally. And when there's a variation in it, like say it's central here, but now it's like off to the left or right on this side, that is generally our way of detecting if they have something called strabismus, which is, cross-eyed, or amblyopia, which is a lazy eye, okay? Well, this corneal light reflex can also help you detect a retinoblastoma. So with it, the other way in which you're evaluating the patient is called the red reflex. So you have this corneal light reflex and then you have this red reflex. With the red reflex, there's actually a red filter on the ophthalmoscope head that you put in front of the light, and you use that to look at both eyes simultaneously, or you can look at them independently. And what you expect is kind of what you would think of if you remember back in the days when we used to like develop photographs, using like a true camera, and somebody would have a red eye on the camera. Okay, that red eye effect that, most cameras now have such technology that it doesn't even get captured. Well, that's expected. That reddish reflection on the pupil bilaterally is the red reflex that we expect to be there. That's normal. An asymmetric one is when it's not present on both eyes, and usually in the eye it's not present in, it's either absent, like we don't see a light at all, or instead of a red light reflex, we see a whitish reflex or a white pupil. And that is what they call leukocoria, or the cat's eye reflex, and that is a diagnostic measure for retinoblastoma. So all of this to say that, we don't have the equipment for me to demonstrate it. This is something that if you decide to go on to advanced practice nursing, you will definitely have in your advanced physical assessment courses, because it is more often done by the advanced nurse, but it can be evaluated by an RN as well if you have the right equipment. So the terminology to know with this, corneal light reflex and red reflex, are two different reflexes that we're evaluating in the eyes. They give us different potential diagnoses. What we would expect for a patient with retinoblastoma is when we're evaluating the red reflex, there would be this asymmetric reflex where on one eye, the one that's affected, would have a white pupil or absent red light reflex. If both eyes had this tumor or this retinoblastoma, then we would see the same thing bilaterally for that patient, and that is called the cat's eye reflex or leukocoria. Okay, moving on. So treatment is going to be a combination of radiation, chemo, and surgery, goal being to remove the tumor but preserve the patient's vision. So trying to have the, visual impairment, if it exists currently, be reversed with the removal of the tumor. And also, obviously, an optimal cosmetic outcome for that patient. In rare situations, there may need to be an actual removal of the eye, but with the hope of having a prosthetic in its place. And regardless of what all is needed in managing this patient's retinoblastoma, for life, this patient's going to require frequent eye examinations. So, it is already something that should be included in every child's, yearly health maintenance, but it would be especially important that it be done often in a patient with a history of retinoblastoma. Little note that it had in your book is that radiation is almost always going to be used. They may require laser surgery or cryotherapy. Chemo is sometimes used, but not as effective because drugs tend to not penetrate sufficiently into the eye, and that is why surgery is often required. If the eye has to be removed, which is known as enucleation, because no other treatments are working, or they fail, there can be, of course, permanent retinal damage, but there is the ability to use a prosthetic for cosmetic purposes. And here is, hey, look at that, a visual of the leucorrhea or the cat's eye reflex. If you notice, if you're looking at the picture on the left side of the screen, that eye, which would be the patient's right eye, has a small little white reflex. That is what we're calling the corneal light reflex. If we could, we would also be seeing kind of a redness, the same size as what we see on that patient's left eye over there, that's in conjunction with it, but we're not seeing that. Okay, the red reflex being normal and this small light being normal. But if you look at the patient's left eye, which is on the right side of the screen, and there's this much larger look to the eye. It has this like opaque look to it, a yellowish white. That is the white reflection in the pupil that is concerning and would be reason to further evaluate this patient for potential retinoblastoma. Okay, so the remaining slides are going to be all encompassing. They are going to speak to just in general. We're not looking anymore at the specific types of cancers. We're talking about cancer in peds in general. What is the clinical therapy, the treatment measures, the side effects of those treatments, what are the information we need to know. So you're going to have to, remember what of this information is relevant to each type of cancer based on what our previous slide said was protocol for that particular type of pediatric cancer. So a child is going to be managed by a pediatric oncologist because of the complexity of what their clinical therapy will include. Clinical therapy includes the treatment of the cancer itself, but also management of the effects that the cancer has on the body and the effects of the treatment on the body. Trying to make sure that things are being preserved, like nutrition and immune function, to minimize harm to the patient. Staging is just simply the labeling of the cancer based on the severity and spread, which is also going to dictate treatment recommendations. Metastasis is, let me back up. Staging is 1 through 4, 1 being the least severe and with minimal spread elsewhere in the body, 4 being the greatest severity and most spread to other locations in the body. Metastasis is obviously the actual spreading to other locations in the body, and we talked about which ones typically have already had that occur when they're diagnosed or are likely to occur even with diagnosis. In your book for goals of treatment, one of the options is curative, ridding the body of the cancer entirely. That is, something I would use loosely because it's just a known fact that even when the body's in remission, the potential for a return or recurrence of it is always there. So we usually don't say cure, we say remission. Supportive is more like your palliative, when you're talking about the things that we're doing to help the patient be comfortable while they're undergoing whatever treatment. So these would be like pain management, antibiotics, if they need transfusions, or other interventions to help the body as the child's fighting this cancer. And then end of life care would be a situation where there is no hope for remission or what they would consider curative treatment. And so your focus is on making the child as comfortable as possible. Therapy can be any combination of the following treatments or even just one of them. And those, remember, include surgery, chemo, radiation, transplant of stem cell, and then complementary therapy would be if we're talking about trying to, do some other things like hypnosis or herbal remedies or I can't think of others right now, but there, I'm sure, are many that you can find listed. All right. Yoga, meditation, prayer. Those are other examples. Okay. Remember, chemotherapy includes use of medications or drugs that kill both the cancer cells but also the normal cells. Radiation is use of unstable isotopes to break up the DNA molecules and destroy the cancer cells. And then surgery, you have both the debulking or excising of the tumor. So either reducing the size or being able to take it out completely. Okay, nursing management of treatment side effects. So these should be familiar to you, and I actually don't know that all of this came from your textbook. I think I had to, piece some of this together using ATI and former textbooks that we've used. So as you're looking at this content, if you're also reading the chapter, don't panic if you're finding that some of this stuff wasn't verbatim in the chapter. I promise it is up-to-date information. It is evidence-based practice. I just may have had to have pulled it from other places to give you a complete picture. So in terms of management of treatment side effects, obviously we know vomiting and nausea is a very expected side effect of chemotherapy. What you would anticipate for the patient who is likely to experience this is trying to prevent it with an antiemetic. An antiemetic that would be then administered to the patient before they eat, so that when they eat, hopefully they don't have that sensation. But also other things can be done, like avoiding strong odors, or the appearance of some foods or textures of some foods may need to be avoided because of the tendency for them to trigger it. And this is an important thing that you're going to maybe be confused by, but it's actually discouraged that we offer the child their favorite foods when they're undergoing chemotherapy. And the reason for that is because the likelihood of them having nausea and vomiting at some point during that treatment is pretty high, and we don't want them to develop an aversion to those foods. So you'll talk about later with the patient who has, really just in a second, anorexia, where they're not wanting to eat. Then we might be tempted to include their child's favorite foods and encourage them to eat them. Like, let's say that their favorite food is chicken nuggets and it's breakfast time. You know what? It doesn't matter that it's not normally a breakfast item. We want to encourage it so that they eat something, but we don't want to do that when they're undergoing chemo, because we know that the chances of them developing nausea and vomiting associated with it are pretty high, and we don't want them to no longer like those foods. So please, please, please pay attention if it's a test question as to what it's asking. At what point in the treatment are we talking about this child's favorite food, whether it's being offered or avoided? Okay, so for anorexia, other things would be small frequent meals instead of large infrequent meals, and providing a pleasant atmosphere for eating. So obviously, reduction of strong odored smells, maybe an atmosphere where like they're able to watch TV while they eat, or someone's there to play and entertain them to increase the chances of them complying. With diarrhea, also with constipation, things that need to be a focus are the nutritious diet they're having. finding out, what are food triggers that are potentially worsening these symptoms and avoiding them, making sure that their INO and weight are being monitored, and if it's situations like diarrhea where they're experiencing, frequent compromise of the skin integrity, then we want to be doing very meticulous skin care for these individuals. Bruising or bleeding is definitely a possibility. And so one of the things that's protocol for that is pressure application to puncture sites for at least 5 minutes. That's a generic rule of thumb. Some patients require longer, some not even that long. Avoiding things that are going to contribute to bleeding, like aspirin and other NSAIDs. Monitoring their blood pressure, but also skin integrity. And just using, gentle handling and positioning of the patient if we know that this is likely a side effect. For these patients that are immunosuppressed, obviously we want to use and encourage good hand hygiene. These patients should not be exposed to crowds. They should not be given fresh fruits and vegetables. As much as possible, invasive procedures should be avoided. And when they are going to be visited by family members and friends, as well as by the staff that care for them, these visitors and staff need to be screened for indications of infection. With hair loss, some of the things to remember is that there should be gentle shampoos utilized for care of that, as well as certain kinds of brushes that are gentle on the scalp. They can be encouraged to use a surgical cap to collect hair when it's likely that they're going to be losing it. Blow dryers should be avoided because they can cause burns to the scalp, and they can use hats or scarves or a wig once they have experienced that heavy hair loss. Fatigue is typical, so we want to make sure that both for the caregiver but us as the provider, that we are organizing our care so that they do still get rest periods, so that when interventions are needed, we try to cluster those so that they have opportunities to rest in between that. Activities that we want to encourage are ones that require minimal energy expenditure so that they're not wearing themselves out, and also knowing that they may need restrictions on visitors so that they do have periods where they're able to rest adequately. Oral mucositis was one that we had mentioned earlier. That is the mouth sores that's typical as a symptom, or a side effect of chemotherapy. And so what are the ways in which we want to address that? We want to make them comfortable. We want to provide, comfort measures. So cool fluids, ice chips would be ideal, popsicles, things of those nature to help soothe the membranes. Oral care that includes rinsing the mouth using a soft toothbrush, applying, barrier cream to the lips. And then also their diet should focus on soft and non-acidic foods, because to have things that are hard or that are spicy are likely going to irritate it further. Okay, this slide, and I think the next might speak to the stem cell transplantation, or HSCT for short. Remember, this is typically a measure used for diseases that aren't responding to the other modalities of care, like they're not resolving with radiation and chemotherapy, or maybe, the ability to surgically remove something. And so this is the next step, and it has multiple phases: pre-transplant, transplant, and post-transplant phase, and you do need to be familiar with what they entail. So the pre-transplant phase, that care is going to include typing the patient, so HLA typing to see who's a match, like if you've heard of Be the Match organization, this is an example of its implementation, and evaluating the patient's organ function. They're going to be in strict isolation. The patient that's going to experience this will have total body irradiation, which means that the treatment is directed at destroying circulating blood cells and the diseased bone marrow. During the transplant phase, so this patient's also going to be in a negative pressure environment in that pre-transplant phase. During the transplant phase, the child will receive IV transfusions of the donor stem cells. The transplanted marrow should start producing the new blood cells in approximately 2 to 4 weeks. And then in the post-transplant phase, which lasts for several weeks, the biggest concerns are infection, bleeding tendencies, and anemia. Obviously, all of our protocols are going to focus on preventing those complications. The child may also be placed on immunosuppressive agents or medications to try to prevent graft versus host disease, which is a form of rejection. And so we want to look at what that looks like as well. So our nursing management for these patients will include all that we've just said: controlling the bleeding, preventing infection and injury, which can result in bleeding, promoting good tissue perfusion, looking for signs or indications of rejection, specifically GVHD, assessing the patient's growth and development, making sure they're getting adequate nutrition and staying hydrated, monitoring their physical activity. We want them being active, but we want to limit the rigorousness of that activity, making sure that they are using good hygiene practices, that there's good oral health being performed, that we're addressing their mental and spiritual and psychological needs, that the family's being educated, and that we're still integrating social relationships and peer interaction for these patients. And this last slide is looking at GVHD, the graft versus host disease, when donor cells start attacking host cells. So the patients receive stem cell transplantation, and now those cells are harming their body. This can be a life-threatening condition, and the indicators that we want to be watching for is a rash occurring on the palms of hands and soles of the feet that is maculopapular in nature. So that's the larger bruising appearance that's occurring, not like the petechiae on specifically the palms of the hands and soles of the feet. This is a complication, obviously, that can occur with bone marrow stem cell transplant that we're trying to avoid with these, the regimen, the medications that are trying to be given to prevent that rejection, but it doesn't always successfully do so. Okay, and I believe that is the last slide, so I'm not going to click next because then it'll just cut off. But this concludes the content for Chapter 20, Heme and Neoplastic, that goes towards this particular unit. So if you have additional questions, definitely direct those to the faculty.